Hi, this is Pat McDonald, your host for Vote for Vermont, where our tagline is listening beyond the sound bites. Ben Kinsley is joining me from Campaign for Vermont, also co-host and co-producer. And our special guest tonight is a repeat offender, Tom Pelham. Tom has been recently appointed to the Green Mountain Care Board. Quite a leap, Tom.
And I will try not to offend.
Exactly. Tom is when he was tax commissioner.
Oh, yes, I was.
Finance, and well, why don't you tell us a little bit about your background, which we always ask our guests.
Well, I'm a Vermont native, born and raised in Arlington, went to Arlington High School and graduated from there. And then went down to the big city in Boston and went to Tufts as an undergrad.
Nice.
And graduate school at Harvard. And I stayed in the Boston area up until about 1989. I always knew I wanted to come back to Vermont and have a family here, which we did. But Boston was very exciting. I got very involved in government in Somerville, Mass., which was a pretty corrupt town at that point in time. There was a whole bunch of these young Turk reformers, both indigenous and carpetbaggers like me. And to our surprise, one time we won City Hall and really changed that city for forever. I mean, it was a good government. My last job down there was as the first director of development for the Mass Water Resources Authority, which was set up pursuant to a federal court order filed in a case by the Conservation Law Foundation to clean up Boston Harbor. So you might remember that whole debate between, I think it was Dukakis and Bush, where Bush held a press conference. And it was true. Boston Harbor was a mess. And my job was to put down, it was a $4 billion in those dollars back there. My job was to put down the staging and laydown areas for construction materials and all the workers to get to Deer Island because they couldn't go through the windy little coastal streets in Winthrop. So, and we had to stay out of downtown Boston because of the big dig. So it was I look back on it and think, you know, how does a little guy from a Division III school in Vermont do this stuff?
Well, exactly. Especially what you're doing takes some serious training.
Yeah, well, it's you know, by then I had developed knowledge of the transportation system in Boston, and so you know they came to me and said, "Could you do this?"
That's great.
And I could. I didn't think I could.
You should do a show on that. That sounds fascinating.
But I didn't think I couldn't either. Yeah. So you know, sometimes fear almost just drives you. But you know, we ended up getting Suffolk Downs as a place to intercept workers coming down from the North Shore, and an old naval base in Quincy to intercept from the South Shore, and the old Quincy shipyard as a place for construction materials.
Cool.
And it all worked, and the project came in under budget, but by then I was back up here.
Yes, exactly.
Wow. So I came back up as in the Cunin administration as Deputy Commissioner of Housing.
Right.
And then Governor Selling appointed me Commissioner of Housing, and then Governor Dean asked me to come up to the 5th floor and be the Deputy Commissioner of Finance, and when my predecessor, Doug Wasick, left, I became the Commissioner. And so I was able to, back then, manage a budget that was almost $4 billion, which, again, for a little guy from a Division III school.
Not too bad.
I was also elected a state representative for
the
Washington 6th District, which is Calais, Plainfield, and Marshfield. And then I came back out of the legislature as tax commissioner in the Douglas administration and deputy secretary of administration in the Douglas administration, and then worked with Ben at Campaigning for Vermont.
That's great. Well, welcome. And now you're a member of the Green Mountain Care Board. Now you had to apply for that job because they were soliciting resumes. So you actually wanted to work on the Green Mountain Care Board.
Yeah.
Can I ask why and what attracted you to all that work?
Well, the why is, you know, is kind of an existential caring about Vermont. You know, I think I've done good work. I think I'm fairly well regarded. I'm not overly political. I've not worked in either of the governor's campaigns I've worked for. But I think I've done good work for them and been helpful in that regard. Healthcare is a big deal. It's bigger than education funding, and we know what property taxes, you know, mean to Vermonters. It's almost 20% of the state gross product. It's $6 billion in an economy that's a little over $30 billion. And so it's a place that's also exciting because it's in transition. There's been a lot of effort to try to replace the fee for service system that we have, not only in Vermont, but at the federal level too, with Medicaid and Medicare. But to give you a sense of the opportunity here, if you kind of start from the big global arena, the United States is the highest spending per capita country in the world, in the industrial world. We spend far more than the number 2 one, and we're spending about $8,000 a year per capita in the United States. Vermont, within those 50 states, spends the 8th most. So we're spending a little over $10,000 per capita in Vermont. And if, just to give you a sense of scale, if we were spending at the same per capita rate as our neighbor New Hampshire, we'd be spending $325 million less than we do today. And if we were spending at the same rate of as New York, which is ranked number 7, we'd be spending $257 million less per year. So the leverage here is big. And it's not a steady state administrative situation. There are good people, both in the healthcare industry and in government, trying to bend this curve away from fee-for-service, which is kind of makes budgets a vending machine. If you need more money, you just do more services, you know, to a system that emphasizes well-being. There's a statistic I learned recently that kind of stunned me, that in the kind of world of morbidity, of kind of what sickness is and the intensity of sickness, only 10% of it is tied to the healthcare system. 30% of it is tied to your genetics, 40% to your individual behaviors, 15% to your social environment, income, et cetera, neighborhood, and 5% to physical environment.
So you're saying 40% of what I choose to do, like just putting it in my own words?
Well, 100% of what you choose to do affects you.
Yeah,
but
no, but you just said 40% of personal decisions.
That's right. That's right. So, you know, if we can encourage our system to not be so emphasizing intervention on the back end, but intervention on the front end, and encouraging people to, you know, keep the weight down. And thank you for noticing that I've lost a little weight.
I did. You look very handsome. I'll say it in public.
You know, handsome. Woo,
handsome.
You know,
serious.
Blushing. You know, so. You know, so I find this an exciting world, and I was, you know, I was at an age where I still have some fire left in me, and I didn't want to go back into an administrative job. I've done.
Right. Yep.
I think you've got me beat. I think we figured this out one day that in terms of administrative jobs in state government.
Yes, I've got you beat, but it's the hours that would kill me. The 60, sometimes 70 hours a week working. It's ludicrous. It's just crazy. It's weekends, nights, holidays. It doesn't matter. You're just working.
I'm in that ballpark now, but I don't think it will be forever. I've just got some climbing to do. And it's exciting.
That's great.
I find myself going back, and you know, I'll talk to you a little bit about the nominating process. So, nominating process is an interesting one, where there is a nominating committee. It's of 9 people, 3 appointed by the House, 3 by the Senate, and 3 by the governor. And there's an application process, and then an interview process. I actually had Lyme disease. Was in the middle of a Lyme disease situation when I went through my interview, and I was surprised. I walked out and I said, that kind of felt okay. I think I did okay, you know, but it's also was like a healthcare experience going on, you know, on at the same time. And so I guess I made it on the list that went to the governor. And the job of the nominating committee is to send to the governor, kind of like they do for judges, the list of all qualified people. And I got a call from Governor Scott one day. I actually got a call from one of his staff saying, "Do you have a number? The governor would like to call you." And I thought, "Uh-oh, here comes the bad news." And he called and said, "Well, I've got some bad news for you and some good news for you." And the bad news is I want to appoint you to the Green Mountain Care Board. And the good news is you're going to work your tail off.
Yeah, there you
And,
go.
he was right on both counts.
Yeah, well, that's a lot of I'm serious. Now, were you, just sort of off the question, but did you get involved in the healthcare at all during your other jobs? I mean, I'm assuming financially you must have been in the weeds.
I mean, obviously, when you're finance commissioner, you have to deal with Medicaid.
Right.
And it's not even the elephant in the room, it's the bull in the room.
Yeah.
And with caseloads, and especially coming into recessions.
Right.
I had a very good familiarity with Medicaid, and had a lot of energetic conversations, let's say, with Con Hogan and Jane Kitchell, because she was social welfare commissioner and Con was secretary of human services. I was finance commissioner when Governor Dean proposed, and it was enacted, the Vermont Health Access Plan, VHAP, which was the first major expansion of Medicaid.
So you got a good history
in,
here.
in Vermont.
Yeah.
And that again was, I was involved in it from the fiscal end, but definitely in the weeds, because we didn't want to make a mistake.
That's good.
Governors don't like to make mistakes, but Governor Dean really wanted to expand health care to more Vermonters.
Right.
And then when I was in the legislature on appropriations, along with Patty O'Donnell, who was a Republican representative from Vernon, we proposed, and to our amazement, it was fully embraced by the legislature, a major restructuring of the premium and copay system. Prior, the emphasis was on copays and not so much on premiums, and not a lot of people liked that, because for the hospitals, collecting the copay was often difficult, and for Vermonters, it was a regressive system. If you had a flat copay, you paid a higher percentage of your income at the lower end of the income scale than you did at the upper end of the income scale. So we were able to work to get the copays down to just one, which was emergency rooms. And the reason that was kept is because people were using the emergency rooms as their doctor's office, and it was felt, and I think rightfully so, that would be an incentive for people not to use the emergency rooms. And but that legislature, it was a Republican legislature at the time. Walfried, I think, was Speaker. I think it was a Democratic Senate. Jim Leddy was the chair of Senate Health and Welfare. And you can go and read Act 66, Section 147, and there's pages and pages of detailed reforms.
Patty was smart. She's a hard worker when she was in the legislature.
And and she was on the Appropriations Committee. Human Services was her section of the budget.
Oh, okay.
So it didn't come out of House Health and Welfare. It was, I mean, you'll find that in the budget bill. You'll find this healthcare reform in the budget bill.
But out of approps.
Out of approps, House of Probes.
So your appointment did get some pushback. There was a couple advocacy groups out there that were pushing back. Can you explain what some of that pushback was, and if there's anything people should be paying attention to as to why?
Well, I think it was a lack of knowledge. I mean, I'll go to the end before the beginning and get back to your question. I was approved by Senate Health and Welfare unanimously. Some people I've argued with over the years on different matters, but I think there's a respect there that I work hard and I'm not glib about this stuff, and care about Vermont. And my nomination passed on a voice vote in the full Senate. So, and it was one advocacy group, I think. They didn't even show up at my hearing before Senate Health and Welfare. I think what it is, I think sometimes groups worry about profiling, and I think they profiled me. I mean, they didn't know me. I never interviewed with them. I don't even know who they are, but they, kind of thought that there was some leverage using social media to try to interrupt my appointment. And I think because I am a fiscal moderate, I have, I sometimes wore a black hat in the Dean administration because he was truly committed, as was Dick Snelling, to the concept of sustainable spending, and Governor Douglas. But Dean was the one that had the toughest sledding in that regard, because when he came into office, there was a $65 million unconstitutional operating deficit in the general fund, which was 10% of the budget at that point in time. And we had some really rough years.
And deliver some bad news to people.
And to Howard's credit, he delivered the bad news too. I mean, I couldn't have asked for more support from a governor to make
But
tough
isn't that
decisions.
sort of what we're looking for in healthcare? A little less spending? I mean, so if they're, I don't know what they're worried about. I'd like to see us do less spending with a good healthcare system.
I think they're just kind of ideologically advocates for single payer.
Oh, I
And
see.
so that's the answer to everything.
Right.
And it's obviously not the answer because Governor Shumlin tried it. He had a supportive legislature and he was all in, and it collapsed.
Yeah.
And so, so it's easy to have those kind of, broad ideological views that have some logic to them, but you want to make government work for people, and so that's where my head is at.
I think for most of us, looking from the outside and not as involved, I couldn't figure out how we could afford it. Because Vermont is so small, what, 640,000?
640,000.
Now, how the heck could we afford this? I didn't understand it, and it
Well,
turned out that was right.
and it's some of the logic is just flawed.
Yeah.
But it sounds bite.
Yeah.
I mean, the topside stuff is true. Bernie Sanders is right. We spend the most in America of any other country, and in Vermont we spend more than the national average. I mean, he is right in that regard. The solution, I don't think, has to be to turn the whole thing upside down. I mean, at one point, I think you were mentioning to me Vital. This.
Oh, yes, right.
This, that's a government-run system, and it's
Yeah.
totally failed. There was a report that was just put out about it, and it's only got 19%. It's a system that was set up to manage patient records,
Right.
and it's.
Now, does that fall under the Green Mountain Care Board,
No,
sort
it
of? Are you
falls
oversight?
more
I think
under
they use the word
it-
oversight.
Right, we have to find that it's consistent with this kind of state healthcare plan.
Yeah.
But the actual management of it and contract is at DEVA, the
Oh,
Department of
I see.
Health DEVA. What is it?
Uh,
Health.
Yes, it's the basically they administer all the Medicaid dollars.
Right.
Is what they do.
It used to be under another name when I was there,
But
but
they keep changing names, making
Well,
it crazy.
it was
the Department of Vermont Health Access. That's
right.
what it is.
It was a lot of the responsibilities were under BISHCA
Yeah.
before, and then
Yeah.
that was kind of divvied
Yeah.
up between DEVA
Yeah.
and then the Green Mountain Care Board.
So it's so. I mean, the government. I've been in government all my life. Government can do good stuff.
Yep.
But it's to take something that is so near and dear to every Vermonter and take a high wire risk with it in terms of
Right.
moving to single payer, aside from the fiscal issues, just the disruptive issues and insecurity it would bring into people's lives. It wasn't worth it.
Right.
We're at 97% as it is. In terms of people having access
Really?
to health care in Vermont.
That's much higher than we used to be.
Yeah,
Yeah,
no,
we're very close.
with Obamacare, we were at like 94%
No kidding.
pre-Obamacare, and we're 97% now. And I frankly know some curmudgeon Vermonters that don't want the government involved in
Right.
health care.
Right.
So the fact that we have a small percentage, out at the edge, some of those people are just people doing
it by
probably
choice.
know,
Yeah.
I don't want it.
Right,
don't want it.
right.
I'll go sell a couple of cows if I need an operation.
So what I think is amazing, because we've touched on this a couple of times, how expensive healthcare is. Campaign for Vermont this fall, we looked at all these things that are going up. We looked at utility costs, because there were some utility costs that were going up. We looked at healthcare costs. We looked at property taxes, because the December letter from the tax commissioner indicated a 7% increase in property taxes. And that all totaled out to about $2,000 a year out of the average family pocket for 2018. And what amazed me about that, because we talk a lot about property taxes and how those are unsustainable and all that, but $1,300 out of that $2,000 was healthcare alone.
Right.
1,300 out of 2,000 was healthcare, and that's what the average family of four can expect in 2018.
Well, I am, and that's not news. I mean, the legislature knows this, and they know that the system is somewhat regressive in the way it's structured. And I think you can look at it this way. There was a study that the legislature paid good money for, the Rand Corporation, which it's a 90-page document with a lot of nice charts. It's valid data. They tied it back to kind of benchmarks that everyone agrees on are good benchmarks. And what it found is that there is no horizontal equity in healthcare, especially at the low end of the scale, where you you have this kind of ramped up system where you have at the start, people who pay nothing for their health care because they're totally Medicaid eligible, and that's fine. And then you have the next group that are Medicaid eligible, but the federal government says you can charge them up to 5% of their income, for the benefit they get, like Dr. Dinosaur, for example. We don't do that. We charge, Dr. Dinosaur is the only program where there are some premiums, and those premiums today in 2018 are lower than they were in 2003 in that bill that we passed in the legislature.
Oh, really? Well, that's
So-
a great program, though.
Yeah.
Pardon me?
Yeah.
That's a great program.
It is a great program.
That's partially chip funded, isn't it?
Yes, it is.
Yeah.
But so you have some folks paying 0. The next tier up are paying at most 5%, but most of them aren't. And then you hit this steep climb of people that through Obamacare are kind of forced into the exchange, and they're looking at 25 and 30% of their income for health care. And it's, and I've met, and you figure it out, a couple, not a young couple, a middle-aged couple over, it's one of the reasons I got involved in this is because I got angry at something the Green Mountain Care Board did, and did some comments on Vermont Digger. But what drove me was a person that works on my car. He and his wife are early 50s, and between them they were paying $1,100 a month in premiums and had a $5,000 deductible. And so I mean he severely had cut his hand, and he couldn't use the health care he paid for.
Right? Yeah.
But on the other hand, he has the government saying we're going to tag you for 2.5% of your income as a penalty for not having insurance.
Wow.
So there's something out of balance there,
Right.
and it's a problem that can be solved, and I look forward to trying to find solution for those Vermonters that are kind of caught in this vice.
Well, thank you for that.
So can you walk us through exactly what the Green Mountain Care Board does? There's essentially, I think, four main functions, although there's a whole lot of leeway because originally, as you had mentioned earlier, it was really created to kind of guide the single payer discussion, but now that that's kind of fallen by the wayside, there's other things such as regulating healthcare spending. You approve all of the hospital budgets around the state. I believe that's 14 budgets. As well as regulating health insurance premiums. So
Keep going, Ben. You're answering
I
your
know.
question.
I'll let you jump in here. But so Green Mountain, so Blue Cross Blue Shield, MVP, they set their rates. Those get approved by the Green Mountain Care Board. The certificate of need process is also regulated by the Green Mountain Care Board. So I'll let you jump in and expand upon any of those and kind of where you see the board going.
All of it was kind of put together in Act 48, and Act 48 was in 2011, 2011 legislative session, and that was built around traveling down the road to single payer. So the Green Mountain Board, in my opinion, was given some powerful tools to manage to that end. Now, the sections, it's Title 18's Chapter 220, which is all the Green Mountain Care Board legislation. The parts of that dealing with a Green Mountain Care, which was the name for the single payer system, are kind of dead in the vine now because it just kind of crumbled under its own weight.
Right.
But now we still have the healthcare system that's very expensive and growing at rates that are totally unsustainable. And so, my view is, I won't speak for the board, but my view is that those tools are there to meet the 14 principles that are the very first section of Chapter 220. There's 14 principles there. And you have to basically say to the nominating committee do you believe in those principles? And I can't find one that I don't agree with. They talk about affordability, access to primary care, all good stuff. And then the tools, as you get into, are the most powerful one. I think the most powerful one in the long run will be the charge to the Green Mountain Care Board to innovate. That is, we can get into it in a minute, is the Medicare, Medicaid agreement with the federal government, and the ACO. But the other tools that are more traditional are approving hospital budgets and being able to manage them. So, we've just getting now the financials for the fiscal 2017, which was over at the end of September, and there clearly is some I don't want to call them violations, but deviations from the established budgets and outside the parameters that the board set, which is like a 0.5%. And so, this has come up before, there will probably be some intense discussions in the next week or two or month about how that extra money which fall to the bottom line of the hospitals. I mean, they brought in more revenue, they provided more services, but there was a, in the vernacular, kind of a profit to that.
Right.
How that extra profit gets handled. So that will be a discussion. Most of that is tied to the UVM Medical Center. Then you have the certificate of need, which is a long-established approach for approval of capital investments in medical facilities under the concept that much of healthcare is not a highly competitive environment, and you don't want to have every Tom, Dick, and Harry operation out there, building their own systems that compete with each other, and then under a fee-for-service system, or trying to leverage those fee and services to kind of support the investment that they've made.
Right.
So it's a way to kind of rationalize the capital investment in healthcare facilities.
And that was originally a federal reform back in the 80s, actually the 70s, and they actually got rid of it at the federal level because of antitrust concerns. They rolled back in, I think, 86. But a lot of the states have maintained.
You
those
can answer your own
certificate of
questions.
Yes, he can.
Need
He
questions.
does a lot of research.
So in terms of
Rate review.
do you think it's potentially, is it a duplication of effort to both have a certificate of need process for capital investments, but also review hospital budgets?
I don't think so. I think it's also helpful for the board to get into, it's a process that helps, aside from controlling capital investments to a degree when necessary, it's also helpful for the board to understand the dynamics of the marketplace out there. You learn a lot. I've been through one CON process, and it had to do with an expansion at Rutland Hospital. And you just learn a lot about markets and in-state migration from New York, and so there's a lot going on there.
That's not going on at the global hospital
Yeah,
level.
right,
Yeah.
right. That's important to understand at the local level. And also in terms of, some hospitals finding a profit center, and they just get very good at something, or they're
Like
Copley,
Copley.
like
yeah, I
Copley.
wanted to ask
Yeah.
about that.
It's I mean, it's and so then you've got the issues of other capital investments kind of being undermined to an extent. In my interview with the nominating committee, I said that they asked me about this situation. I said my general instinct is that because of the monopolistic situation of some, like our top hospital in
Right.
Vermont, UVM Medical Center, they need to be heavily regulated. Otherwise, they can become a bull in a china shop, but at the other end of the scale, at the primary care level, I think that's where creativity and maybe even a little creative destruction is helpful, because healthcare is not an unchanging environment. It's changing all the time.
Well, it goes back to what you said about innovation, right? If the primary
That's right.
goal of the primary care board is to encourage healthcare innovation, creating space to do that.
That's right, and we should not be a board that looks to keep everything rigidified, and just protecting the special interests, that
So,
are.
Tom, what was the issue with Copley? Because I think all of us read it and didn't quite understand what was happening. It sounded like they were being told they were making too much money.
Yep.
And
Well,
in an environment where
I wasn't on the board when
Right.
that issue came up. But I've seen it, kind of the tailings of it. I do think that the Copley management did a better job of explaining themselves than the Green Mountain Care Board did. They won the PR war and basically said, we've become good at something, and
what's wrong with that?
punishing
And
us for it.
what's wrong with that?
Exactly.
And I think that is a fair thing for them to say to some
Right.
extent. But on the other hand, it is they did apply for a certificate of need. They got approved for a certificate of need for this orthopedic operation, and they made certain commitments that seem to fall by the wayside, given that the market is a wind at their
So
back.
what kind of commitments could they have made that would have an impact on the amount of money that they were bringing in? Because I know people in my own family who were waiting months to go
Well, so
to go to Copley.
It wasn't
to
so
have
much that they were charging. They were still charging what they said they were going to charge,
Yes.
right?
Right,
For the
but
they
certificate.
were volume.
getting a lot of
But they had
people.
more volume than they expected.
Well, I mean,
But is that bad?
so that was an issue with the one in Rutland that I did sit
Right.
on, where they came in and basically said this is going to be a replacement building, and a modernization and hallways that two wheelchairs can pass each other, and
Right.
it all made sense. But then when you started to go around and count up, the procedure rooms, it goes, I can't remember the exact numbers, but it went from like 16 to 22. And then you start to ask questions. Well, is this a part of your business that you're trying to grow? And well, we get a lot of business from New York, and it just becomes not necessarily a bad thing, but it can be a bad thing if there is an oversupply of capacity. My view, if Copley is doing something better than UVM,
Yeah, go
then
for it.
and over time, then let Copley be as good as they can be
Right.
within their budget constraints,
Right.
but maybe some of that has to come out of the hide of UVM. If UVM is not,
And they could be good at something else, like heart or something. They could expand
well,
on their
yeah,
skill
but
there.
so it's a fluid situation, and my point is that I don't know how that fluidity will unfold over time,
Right.
but I don't think that we should be so simplistic and rigid to say this is the way the world is supposed to look,
Right.
and damn it, if it doesn't unfold this way, then something's
Because-
wrong.
Well, I think a lot of people were concerned that it was really UVM Medical Center that raised the alarm that, hey, they're technically in
Better than
violation,
us.
and right. So and that again goes back to concerns about antitrust, and because here's a much bigger hospital than Copley, who's basically using the certificate of need process.
But it's also a lesson in the invisible hand of the marketplace.
Mm-hmm.
There were so many people out there that had experiences at UVM and had experiences at Copley, and Copley beat them.
Right.
And in terms of service and attention, I know from board members, that they heard, that they heard this, and
Right.
then you can see the articles in the paper and things of that sort.
Yeah.
Some of it, which is
Well,
Copley advocating on its own behalf.
Yeah.
But that is the invisible hand of the marketplace, and we need, to a degree, to have that kind of softness in the system, so that
I find it fascinating that how it gets out, that word, that,
Yeah.
for
Well-
certain things you go to Copley,
Yep.
for others you go elsewhere.
Well, I think Copley did a good job, as you mentioned earlier, on the PR side of it.
They did.
Because they had a very simple message, and it's like, we shouldn't be penalized for being
Right.
successful.
Right. And another point I'd like to make here is relative to primary care and the absorption of primary care practices in Vermont. I think it very important that we have a healthy amount of independent primary care practices in Vermont. Primary care folks are the closest to their patients. They know what's going on, and to be a primary care physician, you need to love it. But they're also in a position to say the emperor has no clothes, and we need folks out there that can say that, as opposed to primary care physicians that might find themselves more comfortable as part of that large corporate structure and maybe feel a little restrained.
I think in this area, they're all associated with the hospitals.
Right.
A little strained restrained to speak truth to power. So one of the, this is just my kind of initial thinking about this, but I've had a couple of sessions with an array of primary care folks, and I like them. There's a curmudgeonness about them, and they will speak truth to power when necessary.
So it's interesting that you mentioned that the difference between a hospital provider and an independent clinician, because you mentioned earlier that Vermont spends roughly $10,000 per capita on healthcare expenditures. We're number 7 in the country. We're number 3 in the country when it comes to healthcare expenditures at hospitals. We spend
Sad but true.
We spend twice the national average, almost $3,700 per capita per person in the state on healthcare at hospitals. We spend 30% below average, the national average, on spending at clinicians, so independent doctors. It is the largest spread out of any state in the country between our independent doctors and our clinicians and our hospitals. That is something that we should be very aware of as we're trying to address the overall cost of care is the differential between the clinicians and hospitals because we're seeing, as you mentioned, a lot of them getting swallowed up into these larger hospitals.
Well, you can see this. I mean, this is the recent results, 2017 of the Commonwealth Fund scorecard, and Vermont is ranked according to all of their criteria as the best in the country.
Right.
And we are the best in the country, and we should be very proud of that.
May I say we are the best at service delivery?
Service.
at-
Well,
at results of-
access and affordability,
Okay.
we're ranked #1. Prevention and treatment, we're ranked #1. But to your point, avoidable hospital use and cost, we're ranked 13th.
Right.
You know, I mean, we're still in the upper tier.
Affordability, we're #1?
Pardon me?
You said affordability?
Well,
No,
What does
no,
it mean?
access and affordability. And I think that has to do with the expansion of Medicaid in Vermont.
Right.
You know, and Dr. Dinosaur
Yeah.
and CHIP and
They're
those
looking
kinds
at
of
Most people would
out-of-pocket.
say it's not affordable.
they're looking at out-of-pocket costs.
Oh, okay.
Yeah.
The qualified health plans, I don't think are affordable. You know, and that's
Yeah.
and that's something that we have to work on. I mean, there are 2 levels of subsidy in those. These are the plans that Obamacare says
Right.
that go through the exchange.
Right.
So you have
You've got 2
this
choices, right?
exchange. Well, you actually have 19 choices in the exchange, but only the silver plans get subsidized.
Oh, I see,
And
'cause that's what I was
that's the
reading.
point
Yeah.
that you're
Okay.
trying to make. And so, you know, Obamacare set up the structure for plans in terms of, it's called the actuarial value, where, which is the expected percent of your cost that the patient's going to have to pay versus the insurance. And so if you get the platinum plan, it's like 90% of the cost. You pay a higher premium,
Right.
but maybe a lower deductible. But the expectation is that insurance policy will cover 90%. And then as you work down to the bronze plan, it goes, you know, bronze and then
just steps.
platinum and then silver and then bronze. And so bronze, it's expected at 60% a coverage rate. But the ones that are subsidized are the silver plans, and there's 2 levels of subsidy. There's a thing called the advanced premium tax credit, which will help on the premium side, and then there's cost-sharing reductions, which will help on the deductible
Yeah, right.
and copay.
Right.
So they lessen the the cost burden. But one of the things I want to get DVA to do, and only DVA can do it because they have the income data, is I want to see an actually case study of the profiles of affordability of people across
That'd be
these
great to
plans.
see.
The Healthcare Advocate just put out a very good paper, you know, on affordability, but it was a kind of an academic, you know, taking 3 approaches, and all of them affirm that healthcare for certain folks in Vermont is not affordable. The RAND study showed that
Right,
too.
right.
But you know, I would love to get the real-time data, say for calendar 2017, you know, of affordability in Vermont, so that that it's just that you can see it in its detail, which will also mean that you can solve the problem more readily because you really understand where it is.
So in addition to that data that DVA has, the Green Mountain Care Board also has jurisdiction over VH Cures, which is the payer data. It's looking at what the insurance companies are paying hospitals for services provided, what the out-of-pocket costs are for patients, as well as what hospitals are charging for the services they're providing. So it's kind of got all 3 buckets in there, and for those who are not in the healthcare policy world, those are not always the same thing. But this is kind of a central database that collects all that information. And there's some good reports actually that the Green Mountain Care Board has commissioned on on that topic, and even the state auditor has looked at. He's done, I believe, 2
Well,
reports now.
we're going to, I mean, there's an evolution here that I want to get to your point, but let's step back here about reform. Reforms in healthcare, at least in Vermont, go all the way back to like 2003, where it was the blueprint for health. And then you had, in 2005, the 1115 waiver, which was an agreement with Medicaid and Medicaid that allowed Vermont to have more flexibility in how it invested and spent Medicaid money. Then in 2008, V-Cures came along.
Right.
And then in 2011, Act 48 and the Green Mountain Care Board came along. And now we're kind of going live with the ACO, which is this prospective payment approach to healthcare. So it's important to understand the incremental evolution of the tools in order to get us to a different place and away from fee-for-service. V-Cures is very important.
Right.
And we now, for the first time at the Green Mountain Care Board, have our data analytical staff fully staffed with very good people.
Is all payer in there somewhere?
Pardon me?
Is that the all payer
That's
system? Is
ACO,
that
and actually,
That's
ACO?
right.
can you so ACO, and I think a lot of people get confused on what all payer is as opposed to single payer, and some people have called all payer single payer 2.0. Can you explain to us
Yeah,
a
the
little
all
bit
payer.
about what all payer is and the ACO? We've talked,
Well,
mentioned it. but-
all payer is an evolution of the federal government's relationship with us in order to try to leave fee-for-service in the rearview mirror and move to a different method of payment. I mean, we are still substantially on a fee-for-service system, and it's very expensive.
Right.
Because basically, if you provide a service, you get a fee, and so it's based on the volume of services as opposed to other indicators like the health of the population.
Right.
And so it's trying to get to a so we have an agreement with CMS, the Center for Medicaid Services, and it's a 5-year plan that incrementally kind of builds in Vermont prospective payment for health services. For example, in 2017 was the first year, it was kind of a trial pilot year for that, and there was about $18 million in the UVM Medical Center's budget that was spent toward prospective payments to providers within their system. In the 2018 budget, that's up to $162 million.
So they're phasing in.
Yes, which is almost 10% of their budget. And so, but there's a lot of iterative learning that has to go on as that process unfolds. V-Cures and the use of data is one of them, because we're kind of moving to the point where insurance companies are kind of being squeezed out a bit, but the whole actuarial effort that always has happened with insurance or with retirement systems,
Right.
et cetera, has to be developed in a way that can kind of globally manage something like the ACO, which is trying to move providers from a fee-for-service system to a prospective payment
Is
system.
that where the legislature wants the board to go? I mean, because.
Oh, we're in, yes.
You're
No.
all in sync, and that's,
No, I mean, there's 5 years, this is a 5-year plan.
Right.
We have the agreement with the government. We have the agreements with the commercial providers, Blue Cross Blue Shield. I mean, everybody is vested in
Good,
this.
okay.
But it's not like single payer that all of a sudden there's a magic wand in a new system. It is I think, responsible and thoughtful, iterative unfolding to get us from a system that doesn't work, and we all know it doesn't work, that leads to 6-7% increases every year, to one that is good for patients, is good for the providers, gives them stability, and is good for taxpayers and ratepayers.
So essentially, my understanding of the 10,000-foot view is that you have these accountable care organizations known as ACOs.
We only have one in Vermont.
We only have one right now, which is basically a joint venture between UVM Medical Center and Dartmouth.
They're each 50-50.
There's 50-50, but there's a number of other hospitals and providers that have bought
That's
into
right.
the system.
And some that haven't.
And some that haven't, because it's an opt-in system.
Right.
But essentially what it does is the ACO negotiates with Blue Cross Blue Shield, MVP, all those other insurance companies for what they're going to pay. And then the ACO turns around and says, all right, so we are going to work out an agreement with all of these hospitals for their targets, and then they're reimbursed based on whether or not they reach their targets, instead of how many patients they treat and what they treat for.
Well, and I mean, it's a lot more complicated
Right,
than that.
there's a lot more going on.
There's a whole bunch of actuarial work and these kind of attribution of lives and these quarterly reports that get updated to providers because, you know, the attribution is basically based on where is your medical home, who's your primary,
Right.
you know, care provider, and that changes, you know, so you've got this.
It's very fluid.
You've got this fluid market going on out there, but that information's available. It's available at Medicare because they know who they're paying. It's available at Medicaid because Medicaid is making payments, you know, to providers, and it's available at the insurance companies because they also know who they're paying. So the data's there, and now it's just organizing it to kind of track the market out there. Because in the ACO, there's no requirement that you go to this or that provider. You can have free choice. There's no requirement that providers even be in the ACO. But you know, the hope here is that people will gravitate toward it because it's a better place to be.
Right.
It's a better system to run.
In this system, though, have you been focusing on the fact that we're a little short on physicians? There's a real shortage. So is that something that the board's
Yes.
obviously
yes,
conscious about, but doing
yes.
something about?
It's interesting because we in Vermont have the highest number of primary care physicians among states.
Really?
And I've asked primary care people, is that really true?
Yeah, that doesn't sound it from what you've
but-
heard.
And it is. But the problem that I see that our primary care folks have is that they are burdened with things other than taking care of people. You know, for example, they're burdened because Vital didn't work. And so now they're still doing the old faxing
Yeah.
and then calling and following up. They're burdened by a prior approval for drugs system, which is just this kind of wet blanket on their ability, you know, and they've come forward with proposals that make sense. I mean, rather than burden every primary care physician with this prior approval system, the insurance companies statistically know the ones that are problems,
right.
one that aren't. Deal with the ones that are a problem,
Right.
and leave the other ones
Are they
alone.
fixing Vital? Is that being resurrected, or are you going to come up with something else?
I hope it's an important tool
Yeah.
to link this, you know, these disparate kind of operations in the healthcare system. Mike Smith has taken the job. And I worked with Mike, and he is a very focused
Yes, he is.
Yeah.
I've worked with him
and
too.
purposeful person, and he doesn't take inefficiency and
Because that's a shame that didn't work, because that
lack
made
of.
the enormous
Well,
amount
it
of
hasn't worked
sense.
so far.
Yeah.
The study that came out is absolutely condemning.
Right.
You know, it's just bad governance, bad performance. It's just
Great.
it's not good. And the result is, and one of them seems to be the early conditions, is that most states where they're, because this was all subject of a federal grant and every state
Yep.
got it, where it has worked well, it was an opt-out system. In other words, your medical records,
Right.
you have to affirmatively say, I don't want them as part of the
Because.
system.
Yeah.
That's right. In Vermont, it was an opt-in system.
Oh.
And so aside from the technical
Well,
complications.
that's the same with Catamount. I think that's why that failed, right? It was people joined when they needed
That's right.
surgery and then backed out when
That's
they
right.
didn't.
So you had with your physicians help opt in,
Yep.
and it was just another administrative burden on
Right.
physicians, and so you basically have a system that, according to the study, only had 19% of people's medical records in it, and it just
I didn't
wasn't
know that.
usable. But when you think of the inefficiency of that you can talk to a primary care physician, and they will say, you know, I have sent my patient to a technical person up the line,
Right.
and sent along with them the medical records, and the
Right.
medical records never got there, and so the technical person, you know, whether it's a orthopedic or surgeon or
Right,
whatever,
right.
goes out and orders the tests again because they want to move the patient along,
Jeez.
and it's just a system that is inefficient.
Right. Well, glad you're on it. In the time left, I just wanted to talk about prescription drugs. There's been talk about doing something with Canada. I just read an article, somebody thanking Peter Welch, Congressman Welch, for his work. What are you all focused on to get our prescription drugs?
That's an area I will know more about
Oh,
on
okay.
Wednesday because that's my first presentation on it. Clearly drugs are an important area.
Yep.
They're about 10% healthcare costs. You again listen to physicians, and they're saying even generics now are becoming so specialized in terms of their ownership that the systems are just being pillaged in terms of paying for.
Because there's a bill in the legislature. I don't know if you were following it.
It's in the Senate. Yeah.
That's
That's
encouraging us to
S175.
talk with
So
Canada.
that's the presentation that we're going to
see.
get this at our board meeting on Wednesday. You should come and sit in the
Yeah,
pavilion.
we should go listen.
Yeah,
learn
it'll be
about
interesting.
it. Yeah.
Well, they've tried to do this before. Governor Douglas had a program to bring prescription drugs in from Canada, and and it's just this long-running issue of prescription drug prices continuing to go up.
And Bernie
in the US.
Sanders has had proposals along the way.
And Bernie has talked about it too. Yeah.
It's it could be that just the power of money. It's it's a very profitable business, and you keep hearing, oh, drugs in Canada. How do we know they're safe?
How do we know our drugs are
That's
safe?
right. Exactly.
Well, we especially, I think drug companies today are under a lot more scrutiny because of the opiate issues that we've had. Because basically in the early 90s, they were telling doctors these things are safe, they're not addictive, and now we know that definitely wasn't the case. So I think people are starting to be a little more skeptical.
We can see Canada from here.
Right, yeah. You can almost
Heard that
throw a
before.
stone into Canada
Exactly.
from here.
Some people can see Russia. Wasn't that in the campaign a while ago?
Yeah.
So we have about 7 minutes, and I want to. What else should we talk about the Green Mountain Care Board? I guess because it was established for the single payer. Is there language that should be changed to give that these all payer and everybody move together to
or not change
or not
to
change.
give you flexibility.
Well,
to,
I worry that the legislature can be sausage, and
change every 2
and you
years.
go in there with proposals to change something.
Right.
There's most often unintended consequences.
Right.
I think that we have the authority that we need to make the more fundamental transition, pass or fail.
Right.
It's a high wire act.
Right.
That we have the authority that we need to, over a 5-year period, to get us to a point where our ACO system is what's called up to scale.
Yeah.
That it has right now it's a small percentage of the population, but it's about 120,000 lives in the ACO out of 640,000.
And you keep mentioning 5
about
years. Is that in
25%.
statute that there's an expectation in 5 years that we?
It's in our agreements with
CMS.
I see.
It's a contract with CMS every 5 years.
And is there a
Back up.
really good balance? Because I know there's a couple of bills that are requiring that a physician or somebody in the healthcare system be on the board. But do you feel right now that there's a good balance of, you bring a lot
I
of
do,
skill.
but I think that's a fair issue. When I applied because I wanted to do it.
Right.
And there were physicians that could have applied, and I don't know who the other people were that were
Right.
recommended to the governor. It's a secret process. But if they could have applied too. I'm personally not worried that the provider community is going to be short-shifted here, because they are the other side. It's the yin and yang.
Right.
We're the regulator; they're the regulated,
Yeah, I was
and
gonna say that.
they're very powerful.
And they must have people representing them, listening to
Oh, they have well-paid
Yeah,
people. They
right.
have $500,000 lawyers and
Right.
$1 million leadership.
Because you have a lot of attendance at your meetings, don't you? Fairly.
Yeah, because it's important stuff
Yeah.
that we're doing. But we're paid well, but we're not paid anywhere near where the insurance industry pays their executives, but
Right.
or the providers. It's that they're very well paid, and they're very good at what they do, so I'm not worried about them. If the legislature wanted to expand the board by 2 and have a provider, I do think that you don't want the board to become, for reasons we've discussed here, dominated by providers, and even
Right.
one provider is 20% of the vote. You have the issue about what provider should it be? Is it a surgeon? Is it
Sure,
a primary
right.
care? So it's all those issues.
Right.
So I don't think it's a crisis that there is not a provider on the board, because we can't do anything without that side of the fence, working with us. But if the legislature were to go that way, that's fine. In my situation, I mean, the issue came up because I'm obviously not a provider. I'm a fiscal guy and have a very good track record as a public sector administrator. But by statute, we have these advisory committees that we have to set up, primary care advisory committees and other advisory committees.
So they've got plenty
They've
of
got a
time.
seat
to-
at the
they've got
table.
a-
And they have to have a seat at the
Right,
table.
sure, of course.
Because this is a high wire act, and we need everybody in the boat talking with each other and working with each other to get from where we are to where we want to be.
Right.
I don't sense any resistance in the provider community about getting to where we want to be. So it's a collaborative process.
Is it hard when you were reading your statistics of where we are in the scale of things, about how much the hospitals are spending compared to other states? We're not doing well, are we? No.
No, we're
Is it
expensive.
obvious that there's savings to be had somewhere?
I can't imagine there's not savings to be had.
Yeah,
But it's just, and then you'll understand this, it's somewhat similar to education funding.
Yeah.
Every dollar that a government spends has a constituency somewhere.
Right.
Whether or not that dollar is efficiently spent, somebody will defend
Exactly.
that dollar coming in their direction.
Right.
And so here we have an education system, which is 1.6 billion, where we've lost 20 or 30,000 kids.
Yeah.
We still have the same staff levels that we had when we had 20 or 1,000 kids
Nobody
more.
wants to change it.
Nobody wants to
Right.
let go.
Right.
And the problem is that it's the taxpayer, it's the regular person that gets caught in that breach.
Yeah.
And in healthcare, it's the same. This fee for service system is one that is unnecessarily expensive.
And it's complicated to understand for those of us just reading the paper and trying to.
It is.
Well, it's a similar issue. I mean, we're #1 in the country for education spending per student.
Staffing levels per student,
Staffing
you name
levals
it.
per student, #1 in the country, and it's a similar. It's the same story.
Well, that
in healthcare.
analysis that you mentioned earlier,
Yeah.
that Campaign for Vermont put out, is right on point. And
Yeah.
at some point, you break the back of Vermont.
Right.
You know,
Yeah.
people
'Cause they
people
keep
lea-
adding on
people
and adding
leave.
on.
Yeah.
People, that it's just not a place where you can express your enthusiasm in a career and not have a wind in your face, or a strong wind in your
Right,
face.
right.
So I think Governor Scott's on the right track, with his message that we can't make ourselves unaffordable.
Every exempt person we've had in from the administration, they have embedded in their head the things
631.
that 631, the things that he wants to accomplish, and they actually talk about it in their departments and agencies. That what we're doing, is it supporting what he wants?
Well, I'll give you an example. I mean, Howard Dean, a lot of folks in his own party called him a Republican.
He's fiscally conservative.
But he kept his promise to the Snelling family.
Yeah.
He sunset all of those taxes that were increased to fix the recession that we had in the 1990s. And he got the state in a stable setting that allowed us to buy the Champion lands, the Northeast Kingdom, expand VHAP, build the Springfield prison with cash, have our teachers and state employees retirement funds 90% funded, and actually you don't want them 100% funded, because as soon as you get to 100%, the unions will come and say, oh, you've got all this money.
We have too much history. We just ran out of time. I hope you come back when you've learned all this wonderful stuff.
I've only been there 4 months.
Well, you're
but
doing great. Thank you all for listening. And if you want to understand All Payer, the Green Mountain Care Board website has got a one-page that explains All Payer system, where I even understood it. It's a very easy read, so check it out. Thank you for listening. We'll see you next week. And in the meantime, keep listening beyond the soundbite.